usually these research seminars on a monthly basis, the first Wednesday of every month at 3:30, usually. But this is a very special one. We've invited Kevin Leonard from the University of Toronto, and I'll introduce Kevin in just a minute. Before we begin, I just want to let those of you know about some of our upcoming events. Our next Smarter Health seminar is February 23rd. John Glasser from Partners Healthcare will be our speaker. He'll be speaking on areas of IT strategic emphasis in healthcare organizations. I heard John Glasser speak recently at our Future Symposium in Health Informatics. He's an excellent speaker, and I'm sure you would enjoy listening to him. We'll also be holding an HI and bioengineering career evening for students, industry, and healthcare organizations on March the 10th from 4:30 to 7. We'll be inviting industry partners and healthcare organizations to participate in that event, to mix with our students, learn a little bit more about them, and also to introduce your company or organization to our students. So we've had this before. It's been a very interesting and fun time, and so I hope, hopefully, if you're interested in that, please approach me at the end of the seminar, and I'll tell you a little bit more about it. So, to our speaker. We're very pleased to have with us today Kevin Leonard. He is an associate professor, Department of Health Policy, Management, and Evaluation in the Faculty of Medicine at the University of Toronto. He's a very busy man. He's also the executive director of the Improve It Institute and a research scientist at the Center for Global eHealth Innovation at the University Health Network. He has worked in the banking industry and at our sister university down the street, Wilfrid Laurier. We won't hold that against him. And he's most recently at the University of Toronto. He's pursuing the creation of a national patient advocacy program and researching issues pertaining to the development, implementation, and evaluation of health informatics investment. So with this, please welcome Kevin Leonard.
Great, thank you. Thank you very much. What I'd like to do today is just sort of give you an overview of some of the background that led to the development of this institute, the Improve It Institute. And I think the background's interesting because it gives you an idea of where I come from, how I've seen the industry, and as mentioned in my bio, because I've come through healthcare perhaps in a different path than others, and then hopefully engage in a good discussion about where we go from here. And if you have questions as we go through it, I'm happy to entertain that, or if you want to wait to the end, whatever is easiest for everybody, that's fine with me as well. Okay, the Improve It Institute stands for, it's an acronym, and I don't know, I guess years ago when I was working in business and banking, you try and learn catchy phrases, and I met with Dean Siddig. He is the co-founder with myself. Dean is the Director of Applied Medical Informatics at Kaiser Permanente, located in Portland, Oregon. And I wrote a paper a few years ago. He saw it on the web. He likes to say we started dating on the web. He contacted me and said, where has it gone? We ended up talking about the frustration of the industry and measurement. And we agreed that we needed to come up with something catchy. And so over the course of one morning, we came up with this Improve It, because that's what we really wanted to do. We kept coming back to the word Improve It, and then sort of built the acronym around it. But it stands for Indices to Measure Performance-Relating Outcomes, Value, and Expenditure from IT, and particularly in healthcare. And as I'm going to explain to you a little bit of the history and why this became frustrating and why we feel we need this institute, or at least this initiative, in many industries we've had a long-term history of investing in technology. And if you go back to some industries, manufacturing and distributing, wholesaling, 60s, 70s, we started with bringing technology, and information technology anyway, into the areas of billing, invoicing, accounts receivable, moved into payroll, then payables, and so on. So there's been a history of 40 years of processing information using computers, but in healthcare we haven't had that history. Even in those industries, we're still looking to come up with, what's the payback? Where do we get it? We see it. It's accepted that technology has made things more efficient and perhaps more effective, but it's hard to come up with these metrics. In healthcare, we've had lots of frustration for a lot of reasons. One of them, I think, is that we haven't been able to identify that relationship between investment in technology and outcomes, and what I like to call the value proposition of IT in healthcare. And is it efficiency, or is it effectiveness, or is it both? And one of the things that we wanted to certainly address is this whole idea about outcomes, that second point, develop indices for cost, infusion, and outcomes. And I'm going to talk about all of this in a moment in more detail. But what are these outcomes? And we're in the process of, or we're in the business of making people healthier. If we don't have patients, then we don't have a healthcare system. So if nobody's sick, we're out of a job. That's not a bad thing. That would be a great thing, but unfortunately we have illness, we have disease, we have accidents. We need a healthcare system. So if we're going to invest in something that's going to take up a large percentage of future dollar spending, then it better translate into not only just efficiency, but also into effectiveness, which we mean health outcomes. And that's not an easy thing. It's hard in other industries to say, look, I've invested in this technology and I can make 8 widgets an hour. I used to make 2, now I make 8. What's a widget worth? Those types of things. But in healthcare, it's even more nebulous, because how much is it worth to save 1 life, or to have 1 more heart transplant work better, or whatever that case is? And how do you translate that? So we know we've got different measures and different types of metrics that we're going to have to look at, because certainly investment in technology is time and money, but you can translate that into dollars. But what's the outcome? We need to report more of it. In other words, I think we have a lot of success already. We've done a lot of it, but we don't report it very well. So we've got institutions and organizations building systems for the first time again and again and again. Large organizations try and fail, then another organization, another city tries, perhaps even in the same city. And we don't seem to learn from their previous experience. And we need to answer the questions, and I think the third one is really the big one. Like, what are the benefits? Let's identify what they are, and where are they, and when are they? Because if we don't know the timing of it, if you think you're going to invest today and a month later, 3 months later, 6 months later, you're going to start seeing those benefits and you don't see it, then there's a lot of pressure to scrap it, because there's a lot of other factors that are going on, resistance to change and other organizational competing initiatives. We need to know when it's going to happen. And if we can start timing and plotting those things out, we'll know that maybe we're a little behind the curve, a little ahead of the curve, but at least we're moving in that direction and we're not completely out of the loop in terms of when we expect the benefits to hit. So all of those factors, I think, are important. And that was the discussion we had when we first started this whole Improve It. And there's just some basic points in terms of, how do we improve systems without measurement? We seem to be doing a lot of work in terms of scouting out and doing our due diligence in terms of vendors, competing systems, talking to people. But what's the outcome we want? And this is something we just don't do very well anyway. I'm not just talking in healthcare, but just in general. And then coming back and looking at it 2 years later, was that the right metric to achieve our objective? Sometimes we establish the wrong measures. It's not even tied into the objective at all. And often once we have it up and running and we're so busy doing that, we don't come back and look at, did we get what we paid for? Did we get what we expected? Consulting companies come in, help you, make a recommendation, write a report, you go out, you buy the system, come back. 2 years later? Hardly. Sometimes, but usually that's not the case, because they're off in some other project. So evaluation is critical, I think, in all systems, so that we know not only, was it successful or not, but even if it wasn't successful, then why and where. And maybe from that we can learn a little bit about defining the right metrics. And the timing, as I said, is critical if we're going to build business cases. We need to be very clear as to what the relationship is between the investment and this outcome. And it will depend on what the investment is. If you're talking about building a large-scale EHR, that could take 3-5 years. We have to think about what technology is able to do today and what it will be able to do in 3 to 5 years. Should you build a system for today's capabilities or for 3 to 5 years down the road? And being able to articulate, depending on that system, whether it's that or perhaps a physician order entry system, that may take a little less time to build. What are the benefits and when are these benefits? And being able to somehow manage expectations. So in Improve It, our objective was to try and address some of these issues because we didn't feel anybody was doing it. And I think it's one of those things where the timing was right and is right today. And 3 years ago and 4 years ago when I first wrote the paper, perhaps we weren't at a point where a lot of this either made sense or was feasible. But with more and more initiatives in place and more people becoming aware of these questions, it seems to be that when I raise it, there's much more reception in terms of, yeah, we need this. And I think there's a couple other fledgling groups that are trying things. I know at HIMSS there's some analytics group that started. It's not exactly the same type of thing, but they've been discussing the need for something like this as well. So we need to document not only the successes, but some of the failures. And in the fall, November 11th and 12th in Toronto, University of Toronto, we had our first conference on failures. And I know that's sort of a risky word, a risque word. But we wanted people to come in and talk about where they've tried and where they haven't succeeded, and perhaps where they had to try again until they've ultimately succeeded. And I think if you continue and keep at it until you ultimately succeed, then it's really not a failure anyway. It's part of the whole lessons learned process. But we have a tendency to talk about, we did this, and 18 months later we have this. Okay, but that 18 months in the middle, where you think it's failures and you swept it under the rug, is not really failures. It's learning steps and managing expectations along the way that everybody else can learn from. But we don't document that. We don't talk about it because we feel we could have seen it coming. But we can't see it coming. Everybody's doing very similar projects. We're all having the same struggles. We can't all be stupid. So obviously there's a lot of challenge around and a lot of hurdles, and we need to document what they are so that others can see it coming and perhaps avoid it. So I think it's important that we do that. And not only, so that's number one. Number two, measuring performance. And the first thing before you can measure it, you have to identify what the metrics are. And it may sound like a straightforward thing, but we have many initiatives in place. We have a lot of different areas of treatment and so on, and we can create metrics like you wouldn't believe. But we don't have any standardized metrics. And if we're looking at identifying 3 dimensions, which is what the areas that we are looking at, which is how much did you spend in IT, how much do you use IT, adoption or infusion, and what are the outcomes? We don't have a lot of metrics that we all agree on as to what we should be looking at. And I'm going to get to a study that we did just on one of those in a minute. We don't measure health outcomes very well. We can't tell you which doctor does this treatment better than anybody else because we don't have any dimension through which to measure that. We can come up with it, but there's not been a long history of it. Or which hospital does this or which hospital does that. They can tell you how many they do, but trying to perform some sort of qualitative analysis on the quantity is not straightforward. The other thing is that the data is not, we don't have it anywhere. It's not in a tool, and then if we only knew the metrics, we could carve it up and do it. We have to get people to actually that are in the field to submit that. So we have to partner with our members to make sure that they understand, number one, what they're submitting, they agree to it, and they commit to it. So we can tell them, and if they don't like what, or they don't capture that, or they're against submitting that, then we're never going to get it. So we have to have a lot of consensus around that. And then finally, to disseminate that information back, to report it and come up with creative reports and benchmarking so that people can say, look, we're 18 months into a physician order entry project. We haven't seen a lot of success. We've only had 22% of physicians, or 22% of the orders are entered by the physicians at this time. 18 months, let's pull the plug. Then you go and you look at the report and say, well, look, usually it's about 25%, so we're not that far behind. Or it's 20%, and we're actually ahead. how do you make those types of decisions if you don't know what the expectations are? So the reporting and analysis, what we wanted to make sure is that we're not going to say, here's your hospital and here's everybody else and look how bad you are. Because that's not going to be a good start. So we figured that all of it's got to be confidential. So we have to look at whatever the peer group's hospitals are and defining that by size and also by type of investment that they make. So physician order entry versus a EHR would be a different type of comparison. And then you would look at perhaps member hospitals, A through F, anonymized, where yours is identified, perhaps yours to a median of the group, and a number of different places. So you'll be able to find your own, but not identify all of the other ones. Okay, and members will have access to this benchmarking and be able to make different types of suggestions and comparisons as we go forward. And as I said, the peer groups will be defined by the type of the organization, so the size of the institution and so on, but also the type of investment that they're making. Because if they're doing something in physician order entry, that may be completely different from doing something in the lab work, or PAC system, or digital imaging, or perhaps a complete EHR. So, I mean, it will be defined by that. Okay. So I'm going to just step back here for a second, and this goes back a little bit to this history as to why did we develop this improvement? How did we come up with it? And then perhaps that'll give us some perspective in terms of where we go from here. I wrote a paper, I think it came out in Healthcare Quarterly in April of last year, around critical success factors. What defines a successful initiative in IT? 5 years ago, I wrote a paper called My Top 15 Reasons Why We Haven't Had More Success. And in there, I identified a number of different reasons, some of which I'm sure we've all heard before and since, but I thought there would be a necessary paper to sort of put all of this together, because I would start writing other papers and use one or two examples, and I'd see it here and so on, so I just put them sort of all together, listed in one place. And then the journal came to me and said, look, why don't we have some sort of solution? Those are your top 15 reasons why we don't have it, but how do we overcome it? So I came up with this 6 critical success factors. The first one being resistance to change. So the more resistance to change you're going to have, the harder it's going to be to implement new technology. And the resistance to change is really a function about how long the industry has been using this technology. So in a lot of industries, manufacturing, for example, there's very little resistance to using information technology. In fact, they're the ones pushing the end of the envelope in terms of technology they want to see. In the banking industry, you go back 15 years, people were not embracing ATMs, walking into the branch and saying, where's this new machine I can get cash from? They're going to the queue, and branches stayed open longer hours instead of from, 25 years ago, 9 to 3, or 10 to 3, they were open till 6, at 8 at night, and they had concierges and help them walk you over to the ATM, and you don't have a PIN, we can get you a PIN. And, so they had to go through that hurdle. And now, now it's customers that are asking, hey, I want to do stuff over the web at night, I want to pay my bills, I want to apply for a car loan, I want to do all this type of stuff. So there's this functional relationship between resistance to change and history. So over time, this is going to get better, but right now, depending on either the user group, whether it's physicians or other technicians or caregivers, or whether it's even patients, there will be some resistance. And that resistance will be a function of how much history they have. But it will slow down projects. Number 2, amount of training before and during transition. And I'm not talking about training around, okay, let me show you how to use the machine. You punch in your key, your PIN number and your account number and so on. But rather, training and education around why we need it. What's it going to be able to do? What's the link between what you do today, the frustration, and how this makes it better? I don't think we define that well enough, because we work with it so much that when we roll it out, hey, look, this is going to allow you to order your meds or your lab work right on the screen. And so doctors start using it, and all of a sudden it takes them 3 times longer than just by writing a piece of paper, and 20 times longer than just telling the nurse to give them the script. How does this make it any better? But you didn't tell them the back end, which will be all of the other data coding and so on, and hopefully this will streamline and so on. So without that part of education, all they see is that you've just made this so much harder. And instead of having 10 patients on average frustrated out in the waiting room because I'm late with one. I've got 25 because I can't get this dang thing to work. So there's number 2. Number 3, we need to, and this is such a, I teach an undergraduate course in information systems, and every year we do a little quick case, and the case is about not involving the different stakeholders in designing the system. And the students laugh and say, this is so unrealistic. But it happens all the time, that we don't involve the end users, the different stakeholders, in getting their contribution about system design and getting their buy-in. And the two go hand in hand. Because if you ask them what they want, they're getting engaged, they have a user group, and all of a sudden it's their system as well. So it's our system we're building, not you trying to impose something on me. We're doing that with a bunch of physicians on a project in the University of Toronto now about portals, and if they pulled information from other hospitals or other providers, what do you want to see? You can't integrate it because we can't merge the database. We know that. But if you want to look at it, what do you want to see? We can do some plotting, but we're not going to write back to the remote location. We're just going to use that information, import it. How do we do it? And it's amazing to see their growth, which was sort of, they come to the first meeting, their arms crossed and thinking about it, and now they're much more engaged in terms of, well, how do we make this better? Because this is what I'm going to use now. It takes a lot longer, but you're going to build a system that they are champions for. And it's amazing to me how we continue to do that, is to follow, to look, to watch, and then, okay, forget it, I know what you need, I'll build it. And it's not just one side or the other, right? I think all of these problems are arrived at, quite honestly, from groups trying to work together and getting frustrated and just can't. So I don't put the blame on developers or clinicians or whatever. It's just, we just don't communicate very well. Number 4, level of consumer influence during the early stages of adoption. And by consumer, I really mean consumer. I mean the end user. Not the end user of the system, but the end user of the technology, but the end user of whatever that product is. So if it's customer base, they're customers that are buying a new product. For us here, we're talking about patients. Is there any ultimate effect on the patient care, the ultimate end of the production line, if you will? If there isn't, then it's going to be a tough sell for the people to say, well, why am I going through all of this if the patients aren't better off? Can I somehow, with physician order entry, I get a script that everybody reads? Instead of his handwritten thing, and you bring it to the pharmacist, and is that? And they're not sure, and you're not sure, and all of a sudden, you're questioning this and who knows what. But you understand what it is that you have to take. We estimate there's somewhere about $5 million, or is it $5 billion of costs in Ontario alone, $5 billion in Ontario alone, in non-compliance of following meds to the end of their prescriptions. Either they don't take it right, they take the first 2 antibiotics, feel better, stop, they're readmitted, whatever. And a lot of it is not because, I really don't want to take this. It's I don't know what I'm doing. And the other part of it is this whole area of interaction in meds. You ask a patient, and they're not sure they should tell you because they don't want you to stop giving them the blue pill. So I won't tell you about that. And, of course, they'll give you something else, and that interacts with this, and so on and so on. So there's got to be a relationship to that end product. So if at the end, is health outcomes going to get better? If that's the case, then that's going to help make this a lot easier. Number 5, which is really the focus of today, and that is a level of effective reporting on the status of the outcome measures and the performance. We're going to create measures, but we need to know what they are, number 1, and we need to know the progress throughout all of it. Is it getting better or not? And even if things aren't getting better, we should have some sort of status update as to why. Whatever those metrics are. We want to send patients, reduce length of stay. We're going to be able to reduce length of stay because we're going to coordinate their labs better. That's the ultimate. 3 months into this whole new lab project, patients are not only not going home at the same time, they're going home later. So in other words, they're staying in the hospital even longer, another 2 days, because the scheduling's all screwed up. But admit that, because people will know it. But explain it as well, and let's get some progress. And then finally, this whole thing about, there's this catch-all category that I sort of added, dealing with the breaks or the lucky bounce or whatever. We were doing a project at UHN in Toronto around wanting patients to have access to their record in a mock setup. So in other words, they wouldn't get the live record, but a day later there'd be an upload, and they can at least get a feel for what's in the record. You ask patients what they want to see in their medical record, they don't know what it is that they want to see because they've never seen one. So we wanted to engage them in doing that. And there was a lot of pushback from different providers and caregivers saying, well, once you do that, you're going to raise a whole new area of email bombardment, questions, worries, fears, you name it. This is not a good thing. I don't see any point in having anybody access either a duplicate record, and certainly not a duplicate record over the web. Then SARS hit. And physicians were going into the hospital and finding out the patient they saw yesterday has SARS, could have SARS, they're in quarantine. Guess what? You're in quarantine. And then so many physicians, they want to go in the hospital. And all of a sudden, it was a great idea to have a duplicate record being available over the web. And that was able to push a lot of other things forward because of that. So sometimes a bad thing is a break. Take advantage of it, and can help your project move forward. So anyway, I throw that in as a critical success factor. So out of all of this came this technology adoption curve, which really talks to this whole thing on the bottom, which is time. And that is, when are the benefits? Every technology follows this curve. Adoption follows this curve. Now, the question is, what are the units of time? How high is this peak? And how fast can I get over it? And those 6 critical success factors actually are the factors that if you can manage them, you can reduce the peak and shrink the timeline. But basically, when you start, you have a certain level of work. And when you start the transition, it doesn't matter what it is, the workload's going to go up. And it goes up for another period, and then it hits this peak. And usually in between times 2 and 3 is when it's not a good thing. We get a lot of resistance to change. I told you it was going to get worse. It's now worse. Let's pull the plug. And it's not until you get over that people start to see the gains, and then by 0.5, you're sort of at where you were before in terms of workload, but it's a different type of work now, perhaps shifted in different areas, and then hopefully continues on. And you need to get over that 0.3 to get to 4, 5, and 6, or you're never going to get there. And those, as I mentioned, the 6 critical success factors define how fast and how rapidly you can get through that. But we need to recognize that it's not going to be better month 1, day 1, week 1. I don't know what that timeline is, and it will depend on the investment and everything else. But it'll definitely get worse before it gets better. Why? Because you're running 2 systems. People have to flip over. They have to learn a new system. There's training. There's just work. And I don't think we recognize that enough to the point where that's built into managing our expectations. And this is the type of thing that we want to do with Improve It, except fill in the blanks in terms of what these time units are with respect to size of hospitals and type of investment that they're making, and come up with some standards and some confidence intervals around where you see how often people will fall in, 3 months here, 3 months that way, and so on. So they have expectations around how long things take. And not just made up, but this is evidence from 20 other hospitals, for example, that did this before you. Some bigger, some smaller, those types of things. So when we talk about benchmark and reporting, we're talking about much in the like of this. Okay, how are we doing time-wise? I just have a couple of slides here in terms of the success factors, but I'm going to go through it really quickly because I wanted to talk a little bit about that study we did in the academic health science centers. So each page here relates to the critical success factors, the first 5 of them. So the first one was around change management, and I just talk a little bit about, often, unfortunately, we're so busy doing our jobs, we don't think about how we can do our jobs better. And we're constantly thinking about working harder, and you get caught up in this whole working harder scenario. We get a little bit behind. We don't have time on a Friday at 3 o'clock to say, I'm going to take 2 more days off now and re-engineer this process, right? You've got to have something by 5 o'clock on Friday. You're just going to work like mad until it's done. And unfortunately, that gets rewarded, and the next time you're in the same loop and you're in a bigger panic, and we don't earmark enough time to think about how we can do things better. And I think that helps us a lot with the whole change management phase of it. And we don't budget enough time during our day for being either creative or thinking. Walk by the office, someone's staring at the window. What are you doing? I'm thinking. Oh, stop that. Get back to work. We've got no time for thinking in this organization. In healthcare, we must measure the impact and talk about process reengineering. It's a tremendous opportunity when you're adopting technology to re-engineer a process. If you just automate what's there, then you're automating something that's probably inefficient. When does IT adoption become easy or, easier? And this sort of defines some of being able to make that link I mentioned before, that whole training link, not training functionality, but training in terms of what this can do for you. If it creates new functionality, it's easier to defend and explain. And if it replaces existing technology, then it should either reduce costs or improve outcomes. Those make the adoption easier when you're talking about explaining what this new technology would do. Either allow you to do something you always wanted to do and you couldn't, or look, it does what we did before, but now it's cheaper or now it's faster or both. Again, these are just some dimensions. I'll go through this story quickly. I wanted to emphasize that through all of this, this is not just a healthcare thing. This is a technology issue that goes back through many industries, many years. In the early 90s, this was mentioned in the bio, I was working in the banking industry, and I had a consulting contract with CIBC when I was working at Wilfrid Laurier. And one of the areas that I was involved in was this whole area about credit modeling, credit scoring. So using statistical modeling to define who was a good credit risk and who wasn't on a consumer basis. And there was a system called CLASS, Consumer Loan Application Software System. And every branch was standalone. So in those days, it's 91, 92. They weren't all wired and have a central database. They had their own PCs. So at the end of each month, they would have to download their applications, or end of each week, download the applications, and then send them forward to central office and get everything uploaded. But in the interim, they could do their evaluation locally on their PC. But you better make sure that you use the CLASS system, calculate your score. If it's above a cutoff, you get. So in other words, they've implemented this nice consistent process across all of their 1,700 branches, 5,000 banking representatives perhaps, right? But you have a common system. So if you went to one branch, you would get the same score as any other branch because it's the same system. The only thing is that you had to make sure that you hit F10 to save this so that it would be written to this diskette that would then get translated and uploaded to head office at some point. That was the main thing, because people were going through it, getting a score, and then exiting, and then they'd have to redo it again. And what was the frustration again? It's just like the docs, right? I got to do this 17 times before I save it. No. So came up with this idea, this little coaster, and you can see it's like a coaster. I've even used it as a coaster since. But it was shaped like a 3.5-inch floppy, yeah. But shaped like that, but it's just a felt coaster. And on there, don't forget F10. So these things went out to all these branches. And of course, 2 days later, you're getting all these phone calls. How do I get the diskette cleaner out of the computer? Did you read the memo? Why read a memo? But, I mean, the point here is every industry has it. This is 92, right? 91, 92. So unless you explain the link between what you're doing before and what you're doing now, it's going to be tough to make that link, because we know it, because we think about it all the time. We're passionate about it. We're doing it all the time. But someone that's out in the field, this is going to make my life better. If it's not making my life better, then it's making it worse. You're part of the solution or part of the problem. Anyway, sort of an interesting little sidebar. Consumerism and demand for info, industry experience. Again, I'm just sort of elaborating a little bit on my critical success factors that I mentioned earlier, which I've talked about. So I do want to talk more about this study, though. And technology design, development, adoption, and making that link between how things are done today and how it will be done with new technology. And this link that people we must be patient. Because it's maybe obvious to us, but it's not obvious to people that are busy doing their job, who hear it for the first time, who see it for perhaps the second time or in third person or whatever. And then measuring performance. And you know, we believe that, you know, you get what you measure, the whole Hawthorne effect. If just by simply being there and measuring performance, you're going to improve performance. So identifying the fact that we're going to measure it, I think, is a big thing. But ongoing measurement will create better decision support. We're going to learn more. And I think it's just going to escalate in ways that we can't even think of right now. But we can't get to that fifth iteration until we do the third and the fourth, and we can't do that until we actually get started. So we're going to improve and do this better, but we've got to get started. And I think part of a lot of our problems is that we try and create the perfect thing today. We're not trying to create the perfect thing today. We're just trying to create a handful of measures, handful of metrics, define them, get them to report, and get it to get better. And when people start saying, yeah, but why don't you do this way? Then great, then we win. Because it's not me anymore creating metrics. It's everybody else contributing and creating a common pool of metrics as we go forward. And I believe that's what's going to happen. Okay, so if I go back about 3 or 4 years after writing my top 15 reasons why we didn't have more success and thinking about the critical success factors, I had a master's student, Lorraine Peterson, and we said, you know what, it would be really neat if we could do this study on the value proposition of IT. We'll look at how much hospitals spend, and we'll look at what their benefits are in performance. And, you know, surely they have that. Well, surely was the wrong word. And not Shirley, but surely. And because we had so much problems just coming up with one measure of investment, let alone a measure of investment and measures of investment and measures of IT performance. So the availability of the data required was difficult and certainly not homogeneous across hospitals. And you didn't want to do a study with just one hospital. I mean, we engaged a number of hospitals. In the end, there were 8. The accessibility of the data within the participating organizations, some had it this year, some had it 2 years ago because of reporting purposes, some had switched over from a new system, some didn't even have it, they'd have to go back to paper, and being able to make some sort of meaningful comparison. So if we're not talking about the same things, then you really can't make that analysis. You really can't. So we had to come down to some common denominators. In the end, and what I've done is I've taken probably 4 years of Lorraine's life and just sort of shrimped it down to about 2 minutes there and said, we're going to work on the percentage of net IT costs, the total hospital net operating costs. And the paper just came out this last week, or within the last week, in Healthcare Quarterly, and there's an insert section called Electronic Healthcare, and it's on page 99, I think, 94, of the most recent one. And it's called Measuring Information Technology Investment Among Canadian Academic Health Science Centers. And all of the background and the questionnaires we used and the analysis that you did and how we arrived at this one statistic and what that is all in that paper. And, you know, this was her master's thesis, so she was somewhat concerned about whether we were going to finish or not. So the paper became less a statistical IT paper around what's the relationship between investment and outcome, and much more around why don't we have better measurement, which became a much richer paper, I think, anyway, and a much richer thesis. And it was extremely interesting to find out not only why we had hurdles, but who even promoted the hurdles. You know, there was sort of this passive-aggressive things that were going on within the different organizations that maybe I don't really want to clear this up right now anyway. And we can leave that to people's surmise. Anyway, so what we did, we had 3 non-acute and 5 acute hospitals. By acute, I mean I'm talking tertiary care, emergency trauma care. And we looked at 5 different variations of the same thing in terms of dollars and or percentages, but of course it makes sense because everybody's got different baselines, different sizes. So the first one here is IT spend ratio. So that is how much that's the ratio we just defined on the previous page. Without depreciation. We even had some discussion about depreciation, and we had to take it out because not everybody calculated depreciation the same way, over 3 years, over 5 years, some of the years digits, blah, 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 blah. So we had to do that. And you can see that the mean is 3.7 and 3.5. That's the percent, with the median being 3 and 3.2, depending on the 2 groups, and the range being somewhere around 2.6 low end 2.8 up to 5.3 or 4.7. If you included depreciation, then it went up, with the mean being about 5.3 for non-acute and 4.8 for acute hospitals. That's 4.8%. Now, it gives the impression that maybe non-acute is spending more, but don't forget there's an actual raw dollar figure involved, and the acute hospitals are usually having much bigger budgets. So it may look like less, but they actually are spending more. So then you have the bottom line here, as you can see it, total IT spend. Now that's in millions of dollars, so the non-acute is 6.2 and the acute is 16.4, which is what you would expect. So acute hospitals are spending much more dollars, but lower percentage because they have a bigger budget on the bottom line. And there are about 3 or 4 more slides like this in the paper where Lorraine and I divided up in different ways and so on, but it's her thesis was accepted. She graduated, I think, in 2003, and the paper was accepted, except for minor edits and stuff like that, almost right away because I think of the contribution that it makes.
What's the IT? What did you think of as IT? Just hardware and software, or training?
A lot of that is explained in there, but we had to. The questions we got were that, okay, is it hardware? Is it software? Is it the guy that's on the 3rd floor that 4 years ago didn't exist, but all he does now is take data from paper on patients and enter it into the computer? Is he IT? Or does he replace a nursing staff? Or, these are the discussions that you have. There's one guy that's responsible for the networking cables and printing on 3 floors of the hospital. Is he IT?
How did you resolve that, though? Yeah, that's what you resolve. How did you, these numbers, if you go to the previous slide, I hate to interrupt you, but no, just go to the previous slide. And what does that mean? Percentage of net IT costs. What is net IT cost?
Well, okay, in here, it's a long discussion around how we got to that. So, but in the end of the day, we ended up having to look at paring things out so that if you couldn't see, I'm not saying this is the best measure, which goes to the preceding slide, which we're not coming up with the perfect measure. But this was something we all could agree with. You can tell me how much you spent, give me the invoices, how much did you spend on hardware and software? Okay. And do you have FTEs that you define in your hospital that are IT? Yes. Okay, we're going to include them. But I have something like that, but I don't call them FTEs for IT. Then, okay, then they're not in there. So even then, are they really apples and apples and stuff like that? So there's lots of corner cutting. I mean, I wouldn't put this as the be-all, the end-all. This is now the ultimate study. These are the numbers locked in stone. What we wanted to do as a paper is to illuminate the fact that we don't have apples and apples. We got apples, some bananas, some pears, and some things I've never even seen.
Any idea in terms of percentages how it stacks up against other industries? Could you repeat the question?
Yeah. How does it stack up against other industries? Okay, that's a good question. In the beginning of the paper, we report that similar industries, similar figures, because we don't know how they did it, right? Because we didn't do that study. 2.46 in education. So if I'm going to come back here, we're talking about that number up there, 3.7 and 3.5. So let's say we're in that ballpark, 3.5. So for other industries, education 2.46. This is using 2001 data from the Gartner Group. 6.55 in financial services, and 6.84 in the IT sector. So those are some numbers that we were able to get a hold of. But again, there's no guarantee that their numbers and their numerators are the same. And even their denominator, how do you define that? Because they're not in a different same industry. There's lots of issues. Yep. Okay. I think I'm almost there anyway. So this is the last slide. The future. Best way to ensure success is to examine the past, best practice. That's what we believe. We want to be able to go to hospitals and other organizations that have invested in IT and healthcare. We want to be able to see what they've done and use what they've done, whether it's success or failures, or being able to learn from their process, learn from other industries, and provide some insight into the benefits, not just the amount and where they are, but the timing of it. And so what we've done is, with the Institute, we ended up contacting a number of organizations when we went looking for funding. We haven't been able to get large-scale funding yet, but we've been able to contact, and so these are just lists like UHN in Canada, Calgary Health Calgary Health Authority Region. I always get that name mixed up. John Hopkins, Mayo Clinic, Partners Group, on and on and on. There's about 20 or so organizations that are members, and we just want people to contribute data. And we'll do that analysis, and hopefully it brings some value add to the point that brings more and more members. Thank you.
What I'd like to do is open it up for discussion and questions, and you'd like to, Don?
Near the beginning of your talk, you talked about documenting successes and failures. Documenting success is always a pleasure. Documenting failure doesn't happen very often. Airline industry, in some sense, is probably better at it than anybody because of their reporting mechanisms they have. Can you comment on that and how you might do that? I'm very interested just because of your talk, and also something came up in my life yesterday that indicated that it would be very useful to document failures, because let's not make the same stupid mistake over and over again.
Right. Yeah, I mean, that's a great topic for discussion. We can have many beers over that, I think. And Dominic was at the conference that we had in November, and I talked to people to come and present, right? And I picked a lot of these presenters because I worked with them the last 10, 12 years. I know the frustration that they had. And I said, come and talk about this. Come and talk about this problem that you had. And they did. And they came to the conference and would talk for an hour or 45 minutes. And they would do an intro for 5. They would talk about what I wanted them to talk about for about 8. And then they would talk about how successful it's been since. And the tendency is to not talk about where that rich information is, because we don't want to focus in on that. And even though I invited them to talk about just the failure part of it, it's still this human nature to talk about, oh, we overcame it. Yes, great. And this is what you did at the end. But there's so much we can learn. Jamia did, not too long ago, a couple of years ago, a volume just on initiatives that didn't work out. I think it's rare and it's courageous, but we need to do more of it. And it shouldn't be about, we have to really emphasize that. It's not about pointing fingers. It's not about you're done, because we're all doing it. The problem is, like I said earlier, is that we're always continually building these systems for the first time. It doesn't make any sense. There's so many vendors at HIMSS. We got, how many vendors come down to HIMSS? 6,000 vendors? I don't know. I mean, there's so many different, that the chances of building the same system exactly are infinitesimal. So we seem to not share it because, oh, well, you're building something else with some other vendor. But there's the problems that we have are systemic. They're not related to a developer or a program package or a hospital.
Well, I just, Carl, but I just want to point out that being invited to the conference was interesting, because you're invited as a failure. So I tried to give a very, very bad talk, so they would not rate it very high. Mm-hmm. So I would be rated very low as a failure. Anyway.
Just to follow up on something you mentioned early on in your talk, kind of building on the previous point about measuring successes and failures, and you were focusing, I think, a lot on looking at the outcome. But it seems to me there's a lot of value in splitting out the process success and failure from the outcome success and failure.
Absolutely.
And tracking whatever metrics you can get on both of those as a learning exercise. Secondly, I was kind of intrigued by the fact that that was the one measure you could get consensus on, because as far as decision relevance goes, I was of a hard time seeing whether you'd want to be high on that or you'd want to be low on it. You get a number, but what do you want to do with it?
High or low on what?
That one metric you could agree on, the percentage of IT costs as operating costs.
Yeah, that's a good question. I think after a while it was sort of like battle fatigue. And they said, okay, fine, we agree. I don't know what it means, we agree. Take that number. He's not going to go away, and she's got to get her thesis done. If you're persistent long enough, you get something. I don't know if it's good or bad. But I didn't mean to emphasize one over the other. I think learning from successes and failures through the process, through the final outcome, all of that's important. In fact, I think the process is even more important given where we are today, because that's where it happens.
Kevin, the focus of your presentation in the study was on the sort of hospital organizational level.
Yeah.
Can you comment on sort of the value proposition for IT investments by sort of provincial bodies, health authority level? Like, what would you see as sort of the differences in how you would pitch the value proposition?
Yeah, well, first of all, in terms of a study, we haven't done anything like that at the moment. And I know I've been talking with different people in the Ministry of Health in Ontario around, following this type of stuff up with larger scale initiatives. But it's the same issue, right? I mean, you can consider Kaiser Permanente as a series of independent hospitals, or you can consider them as one large organization that's got a lot of member hospitals that are making similar investments. So it's easy to consider the province of Ontario as the largest HMO in the world. Should they be providing some leadership in terms of which systems to buy, or should they just sort of be laissez-faire and you buy what you want and we're going to give you some guidance? Either way, I think there should be that infrastructure to support, which is the type of thing that we're suggesting here. Right? We're not saying that this system is better than that system. What we're saying is that there is some relationship between investment, use, and outcome, and if you manage it effectively, you'll get to see that value proposition, regardless of who the provider is and who the technology company is. And I don't think the scale matters. Yeah.
Thank you. You talked about the dimensions of the metrics. You've mentioned investment, use, and outcomes. And I wonder if you could comment a bit more about the outcome side, because I struggle a bit with the question of whether it's a reasonable proposition that IT investment is actually going to produce outcome benefits for patients in many cases. I think there's a more straightforward argument to be made around efficiency. We can get more patients through the system. We can treat them more efficiently. But to make a test around improved outcomes, I think is a difficult one. And I think if it's a challenge to get a consensus on an indicator of investment, I think it might be even more so around what sort of outcomes could be attributed.
Yeah, I mean, that's a great question, and we've had a lot of debate already. But this is something I'm really passionate about, and that is that the technology investment has to improve health outcomes. And we've had a lot of discussion because there isn't any evidence. But the belief, the logic at least, and in some of the papers I've written, and at the Improve It website, there's a list of the last, 12 years of papers that I've written in this area, starting with measurement and IT in general up to the most recent stuff. So there's about 20 papers. So in there are some of this debate and discussion and so on. But the idea is that the technology, information technology, allows information, processed information, which is decision support and knowledge, into the hands of the caregiver faster. It's accurate and it's faster, meaning that a patient, instead of staying 3 days waiting for something to come back and finding that it is actually in the file across the floor in a different ward, could have sent the patient home faster, we could have had the surgery faster, and so on. If you squeeze that down, that whole waiting time, into some place where it's urgent or emergency, such as in the emergency ward, and you can find out right away that the person is unconscious because of this problem, that problem, this, and not have to go through a battery of tests, get to the treatment, perhaps they don't go into a coma, perhaps there's all sorts of other types of health benefits that happen right away because the right treatment's happening. So that's the logic. So we've built a series of little cases where technology, not by itself, right? We're not talking about robots where something goes in and rips out the bad tumor, but assists the other critical role players, caregivers in the healthcare system to make better decisions faster. Faster ultimately will allow for better health outcomes. That's the proposition.
Yeah, and I think I agree with that. In many cases, though, it's going to be very difficult to attribute one to the other. I think, because part of what you're talking about, say, in decision support systems, is that the care provider, the physician, has ready access to the information about what needs to be done with this patient, which I think has greater potential for benefit for patients than, say, assuming that he might go to the literature and look up something in the process of treating someone. But whether you're getting a system design such that you'll actually know that, yes, the physician went to that button on the electronic record that accessed the information and then followed the guidelines, and that changed his or her decision, and that made a difference. I think it's going to be a
well, they won't have two systems in parallel, right? So if today the length of stay, and I don't care what it is, but let's assume we're talking about inflammatory bowel disease, and the length of stay is 6 days for a certain condition, and then we implement a whole new electronic health record, and 2 years from now, it's now 3.4 days, and we don't have a higher readmit rate, we don't have a higher complication rate, we've reduced adverse errors and so on. Some of that has got to be due to better information. Yeah, you're welcome. But it's a great question, and we debate it all the time. You have the mic, you have no choice, you have to go next.
One other observation, the health system in some sense is rather unique. We have these basically self-employed people delivering health care to individuals.
Yeah.
They're being asked to use these new high-tech systems to help the hospital or whatever relieve the load. They don't see any benefit. So why bother? I mean, from their perspective, I'm being somewhat simplistic, but not that.
Yeah. I'm not sure that's 100% true. I mean, I think doctors see, if you speak to them in a setting that is away from patient care, okay? So if they're sitting there and they want to show you, look, I don't see the benefit of this because it takes me too long. But if you get out of there, and then like some of the research that I mentioned we were doing earlier, and you talk to them, they see the benefit. I mean, that's why they're putting up with all of this, because they know it can add value. But we haven't been able to build a system that allows them to do that. And part of it is explaining that curve. Part of it is so many other factors. The other thing is that doctors spend money in hospitals but don't work for the hospitals. Right? So there's not that same accountability, responsibility that goes along with every single other employee of any other organization. So in the short term, there isn't that motivation. The motivation is to treat my patients. I do see the benefit, but we don't seem to be able to get there. But when you ask them, you're going to be involved in one more research project, by and large, they say yeah, because they know this has got to help somewhere.
Yeah, I have two questions. My first question is, you've shown us the critical success factors, and my question is, what's different in healthcare IT projects? Because as I look through the list, the critical success factors, it seems like it's applicable to other IT projects.
Yep.
I'm also interested to know that if there were any failed projects in healthcare IT, is it more? Are there more failures than the non-healthcare projects?
Okay. First thing, I agree with you. I think a lot of those critical success factors are relevant regardless of the other industries. But our community, the healthcare field, is not involved in other industries. So we got to write it and put it in language that pertains to our industry. I'm not sure that there is more failures or poor adoption, let's say, than there were at other industries at different times in their history. That's why I sort of showed that little thing about the banking industry, because they had a lot of issues and failures too. It may seem like it because we have more technology available, so there's more projects. Maybe the percentage is the same, but it's just more of it. Or it just happens to be an industry that has so much more focus now because it's going through this process while many other industries have already overcome it. So it's getting a lot more of our focus. So it seems like it's more. In this conference, there was a couple of people that I knew from the 70s and 80s when I was going through university that came and said, this is the same thing we had with Dominion Textile in the 70s. And then he would just sit and give me a 20-minute story about this exact same thing, except in their industry. And it's important to hear those stories because it's not just us, doctors, nurses, hospitals, healthcare, Ministry of Health. It's this, it's the whole change issue. Yeah.
My second question is...
Oh, I thought you had two already.
Yeah, I did two. That's the second one. My second question is, I was expecting that from this presentation that I would walk away and find out what other ways can a researcher, perhaps from computer science or management science student doing either master's or PhD, contribute to whatever initiatives the Improve IT is doing. So I'm more interested to know what are some of the more specific questions or research areas that you're looking at, other than just saying that it's hard to come up with measures in IT.
Well, I mean, part of it is to do that, is to work with these organizations to facilitate, to come up with these measures and get them to contribute and then do the analysis and the benchmarking and track the progress. I know it sounds, I mean, I have this discussion with the people in the dean's office, you know, at the University of Toronto. Is this research? Is it research, really? It's so fuzzy. Is it research? Yeah, it's research. I mean, if we don't do it, who's going to do it? So, I mean, I'll put it out there. That's all I'll say.
Comment on one aspect of health that is different from some other industries. Actually, it holds a lot in common with the other knowledge industries. But if you look at manufacturing, for example, there isn't the degree in which a person and a system need to immediately and simultaneously correlate their thinking processes. So the computing actually interferes with the way I think and what I do. A computer in a diagnostic imaging process could interfere, and often interferes with the search pattern used by the radiologist, for example. And that is a very challenging area. But you would find similar problems, perhaps, in an audit, for example, situation where the computer could get in the way of an audit discussion. And, of course, there's interest here in exactly those departments you mentioned. But there are differences, but it's because we're so much more connected to the cognitive aspects than other industries. Mayor.
You talked about the critical success factors. I'd like you to comment a little bit about the amount of resistance to change in healthcare to the adoption of IT, why it is too high other than the other industry, and how these can be minimized or decreased.
Resistance to change can never be overstated. You know, I mean, it's massive. Why? First of all, we are always dealing with human beings, and it's that whole issue that, are you telling me that I've spent 30 years in this industry, and that I could have been doing it better for 30 years? You are now attacking me. Now, if I can just go off topic just for a second. You have a little theater here in Waterloo called the Waterloo Stage Theater. It's showing a play called Coaching Matters. I wrote the play. The play ends February 12th. So you got to go see it. There's like 10 of you. I want to see sales go up by 10 by tonight. I wrote the play because it was a time that I spent with the Vancouver Canucks hockey team, and I traveled with them for a year. So I was teaching at Wilfrid Laurier. I had a leave of absence, and I joined the Canucks. And we built a system, technology system, that was a scouting system that identified players' tendencies on the ice, who they played best against, and so on. And then the coaches would use that to hopefully, you know, organize their lineup and so on. We had coaches that embraced that, thought it was great, and then we had coaches that hated it. And the coaches that hated it, did they really hate what I did? Or did they hate me? Or did they hate technology? Or whatever? And that, I mean, that one character, his name is Jack in this play, he is Captain Resistance to Change for all of those reasons. And he doesn't, you know, he attacks everything. The character that is the statistical analyst, he's an idiot. Computers never score goals. You never played in the NHL. And it could easily be called, Coaching Matters could be called Education Matters, could be called Technology Matters, could be called Change Matters. And I don't know, we should write a book about, I'm sure there are many books about, you know, change management, resistance to change, but I think so much of it is just human nature.
I'd like to comment and ask others in the audience to maybe contribute, certainly the people who have been in the field, to your question about the research areas. I think the very definition of metrics, the ones we're interested in, are metrics of input to the productivity equation, so to speak. Measuring those, coming up with measures that allow you to determine, for example, if you spend $1 million on training, is it on a good training program or a poor training program, or to just do payola to somebody, you get rid of $1 million. The real ability to match the inputs and determine that they're causal is much the same problem that you were coming up with, which is we're showing that a cocktail of a human being, a process, an immediate work process, and a system improves outcomes. But we can't tell which part of the cocktail caused it. And maybe that's not a good question. But there may be dominant or interactive factors with it. That's a research question. There are almost endless research questions in this area. The definition of outcome measures, now the Rooses have done a tremendous job in Canada about that. Things like the indices that they've come up with. I can't remember the term right now, but even that, figuring out a really good outcome index that correlates with the kinds of impacts you're expecting from this particular cocktail, not just health outcomes, but the outcome from this. Like I say, how much better do I feel after a drive versus after a movie? There are different kinds of outcomes. That type of stuff is real research. I dare say that even the definition of that equation is still research, because you escape from answering the question about what net meant and all. I think there's still work to be done in this one consensus index. A balanced set of indices, to go into performance and balanced scorecard, that is research. And I don't know. I'm sure that Paul could comment on this. Do you want to, Paul, or am I putting you on the spot? Like, what research do you see in this area? Maybe Carla has thought about this for a while. Mind if I ask you that question?
I think, it is, I'll just, now that he's given me the microphone, I'll just let my thought processes go out loud here. But I think the issue that Dominic mentioned, you've got a kind of black box intervention in a way, a cocktail you described it of things in some sort of IT intervention that you hope is producing some outcome. But if it does or if it doesn't, you don't know what part of that made the difference. And so in epidemiology, that's kind of a black box sort of question. And even traditional, experimental design methods don't necessarily do very well with that, because you're comparing black box A to black box B, mm-hmm. And even though your design is very rigorous, your ability to know what it was that made the difference is kind of a problem. So I think that in some cases that moves you to try to develop some sort of theory-based approach where you have some sort of conceptual model of what you think is happening, why you think a certain intervention makes a difference, or what aspect of it does what, and then designing measures around that. But it's a much more complicated, unwieldy process. It assumes that you've got some sort of framework or model or theory to work from. But even so, and even if you're successful at that, at the end of the day, you probably haven't been able to do that kind of a study in the context of a randomized controlled trial that some people would accept as sort of a definitive sort of proof.
I guess from an accounting perspective, I could see two obvious ones. One is an issue that somebody's already touched on, which is the incentives to go along with these kinds of changes. We spend a lot of time worrying about incentive structures, incentive agreements, and how that's going to drive it. And I think, as Don already mentioned, when you've got an interesting party like physicians who have a different set of incentives, there's a lot of interesting things about modeling and experimenting with what you can do to get people to be more cooperative. The other one that comes up goes back to a comment you made early on, and I guess builds on Dominic's comment about a suite of measures and the idea of what you might do in a balanced scorecard. And again, there's a couple of different perspectives there. One is, how do we go about choosing the measures? What factors are going to enable us to do a better job of choosing the measures to begin with? And then the second issue is, if you're in a dynamic decision-making world, how effectively can you structure and represent this information so somebody can use it to do better decision-making? Mm-hmm. And that's a kind of a behavioral issue that's mm-hmm. fairly challenging. So.
Yeah, right. I guess the other thing I'd comment on, even as you learned in this or knew this beforehand, that the cost aspects of IT, like what is included in IT. particularly when you've got multiple organizations sharing something. Then you've got the allocation problem, which everybody knows is arbitrary. So you have to choose models of allocation. Do you include a percentage of human resources? Do you include, for example, years ago when we studied picture archiving and communication systems, or go back further, laboratory information systems. The laboratory informations we studied in the 1960s, believe it or not, we did that. I did that. It's hard to believe, but it's true. Those information systems now have been totally, that part of the LIS has been totally removed from it and put into instruments. So it's no longer a cost of the IT, it's a cost of the instrument. And we're constantly seeing that in picture archiving and communication system. The IT disappears into the imaging suite, the MRI facility or whatever. And that's a problem that if you measure IT now and you measure it 5 years from now, you're measuring a different thing.
Right.
The lab information system brings up another one. You go to physician order entry, which hopefully reduces errors and all those wonderful benefits that people talk about. It obviously goes to the benefit of the lab because they get a much clearer picture of what to do. They probably can turn the test around a lot faster.
Yeah.
What about the concept that maybe the doctor should benefit from that? In fact, the lab is saving money through the physician's efforts, not necessarily through their own efforts. So perhaps there should be some, quote, payback, if you will, to people to use these systems.
And I didn't know you had an MD.
Just recently.
Any other comments? Yes.
Thank you. Just another comment is, I think just the nature of healthcare makes it different for measurement. Just because you have the provider, you have the patient, but then you also have a payer. The end consumer, the patient, is not the person who actually pays for the health services. So unlike maybe other industries where you would have that drive from the patient, in this case you don't. And each of these different stakeholders would want sort of different benchmarks, different measurements of healthcare that are relevant to them. And I think that is a characteristic of healthcare that makes it difficult to implement IT and to have measurements for that.
Yeah, I mean, that's a great point, and that leads into a lot of, as Shirley had mentioned in my intro, this whole thing about patient advocacy. I don't think that the patient or the end consumer needs to pay, and in some ways we do through taxes and everything else anyway, needs to pay specifically, but rather needs to be involved. They need their voice heard, they need it coordinated. And if they're not happy with either specific services or specific access or those, they have to be coordinated, or else it's just noise to the system. And that's another talk. It's another area that I'm really interested in. And I think when we get that voice heard, then it's going to start to speak to whether they're happy or not and where the pressure points should be.
Any other final comments? I just wanted to make one other answer to your question of researchers. We've just begun a project, in fact there are 2 or 3 of them now, in the area of the value of information itself. You made me think of it when you mentioned that. If I give the information, what's it worth? I mean, to me, to others, it'll be valued differently. That really is an empty field when it comes to real research. It's wide open. I have one graduate student in that area. Second one looks like it's going to look at it. I know Ken McKay is interested in management sciences. I just point out that there's so much research here, it's almost hard to do. And what you've undertaken is probably the most difficult challenge in health informatics because it's highly visible. It involves failure, in your measurement. And none of this fits well with the world out there. And yet you're getting a good response. And the reason I asked you to come here, not only to meet with you, is that I really believe that what you're doing is extraordinarily valuable. I think I'm very, very glad to see it's happening. I know our institute would like to collaborate with you and bring some of the things we're doing together with yours, but I was very glad to see it. There are very few groups working on it. You visited Boston, you know of Blackford Middleton's work, and there's a group turns out in San Francisco that's got, and also a group in MIT has gotten some money in this area. That's about it. in the world. So it's a wide open and yet incredibly valuable area to which we're seeing money finally dedicated. The President of the United States about 6 months ago asked for $100 million for this area from the Congress. I don't believe that's been allocated. I know Brailer considers this in the United States to be among the most important issues right now. We met with him last week. So I commend you, and I look forward to joining you and gaining value from this and seeing it through. So really, do you have other comments, Shirley? Or?
Well, I just want to thank our speaker for coming today, and I guess as well to thank our audience and collectively putting our heads together to thinking about this. I noticed your comment about we don't spend enough time thinking about things. And so we have spent a little bit of time on this, and I think it's been very useful for us all. I've enjoyed it tremendously, so thank you very much for coming today.
Thank you.